Erin, how do we get to answer this question? I don't know.
So if you go either on your computer, you can go to polleverywhere.com/Erin Putney 765, or on your phone, you can text, and you text Erin Putney 765 to this number, and then it'll tell you you've joined, and then you can put in A, B, or C, or D, which I realized I spelled A
All
wrong.
right, thank you.
Looks like a small group this morning.
Amber said she was having a hard time logging on.
Dang it. I know Rachel was trying to log on to a meeting one time, and it kept giving her some Spanish person's name and saying they weren't letting her in. So. If I put this kind of angle, the reflection's just off my computer monitor. Okay. For my people that said hemorrhagic, why would you say hemorrhagic stroke or hemorrhagic shock is the worst?
If it's in the brain,
that's a hemorrhagic. That's a hemorrhagic.
Most
stroke.
likely. Oh.
This is shock.
I
But
mean,
yeah, you're right. A hemorrhagic stroke is definitely the worst when it comes to strokes.
Okay, I was thinking about that, but this one still.
That's okay. So what would make hemorrhagic the worst?
I mean, you're losing a lot of blood, so.
Okay. Loss of blood, but you guys, a lot of you picked hemorrhagic over hypovolemic. So
to me, hypovolemic is the less dangerous one. That one can get corrected with like IV fluid.
Okay.
But
awesome.
the other three are kind of equal to me, because you can die from a septic too.
Well, you can die from all of them, but yeah, that's good thinking. Good. I mean, you guys, there's really no right or wrong answer. Septic is usually one that I'm a little more cautious about, because it comes from infection. And so it usually means if somebody's gone septic, it usually means we've missed a lot of symptoms beforehand. And so that's kind of an issue. All right, good job answering some questions there. Get us started thinking. All right, so let's talk about what kinds of questions you guys have.
I'm pulling up the Muddy Buddies thing. I found a question on there that I want to ask you.
Okay.
I just forgot what it was. Sorry.
That's okay. I'm seeing if anybody's anything in the chat.
I know you were talking about like the shaken baby syndrome,
Okay.
like how that can cause like a brain injury.
Mm-hmm.
So I know you said that we were going to talk about it a little bit more in lab. So if you want to,
We talked about it in the last lab. So
We did.
it's on the recording for that. But yeah, I mean, it's just,
okay.
it's that if you take a baby and you shake them, you're giving them that whiplash effect, and that brain is sliding in and out of the in the skull. So it's sliding around. So yeah, the shaken baby gives a head trauma, you know, but it just doesn't look like it all the time. And that's why it's really important for us to understand what that child is going to look like versus a kid who falls off their bike. Because shaken baby, you're usually not going to get a shaken baby that's 5 years old. You can, but you're usually not going to. So you're usually going to get a shaken baby that's much younger than that. So you guys are all emergency experts. No one has any questions? Here's something to think about. What situations have you been in at work that you either didn't understand what was going on or you questioned the nurse and the decisions that were made?
I work at a nursing home, so I don't really see very much emergent situations. We just kind of send them to the hospital if they're getting sick.
But you do. Why do you send them to the hospital?
Because we don't really have the tools to help them when they're
But
having like a
what-
heart attack and stuff.
But Christina, what are you seeing that's making them have to go to the hospital? There's a transition there. It's not like all of a sudden it's like 1 minute they're in the facility and the next minute they're in the hospital. There's something you're seeing happen that's putting them, that's making you send them out.
Status or like their vital signs or how they're acting.
Okay, what's happening to their vital signs?
Well, I don't really know for sure, but I just know that when they're like sweating really bad and complaining of chest pain and their blood pressure is really high and it's not relieved by nitroglycerin, we send them
Okay.
out.
So what does all that describe? What all are you worried about? When you see those things, what are you worried about?
Heart attack?
Yeah. Like when I see these things, when I see somebody that's sweaty, chest pain, can't really put HA, that looks like headache. Okay, that's an emergent situation. That's somebody you're gonna send out. So you guys, what I'm trying to get you to think about is, as LPNs, you aren't gonna be working in the ER typically. I mean, some of you might work like in a small rural county ER, which is fine. You're going to be working in facilities like doctor's offices, rehabs, long-term care, Alzheimer's units, all of that stuff. You have emergencies in your facilities. You have to be able to start recognizing what it is that is putting us in an emergent situation. You're not necessarily crashing and coding, right? That's more the ER. And then the ICU is intubating and stabilizing and saving, okay? You're not necessarily doing any of that stuff, but you're the first, like when we talk about these first responders and first line of defense and, you know, people on the front lines, you guys are the ones on the front lines. You're the ones in the facilities watching the things happen that we miss, okay? This is what I see a lot. And on Monday, we're gonna talk about some of the things that I've seen really missed, okay? About what do we miss that is going on. So we've done a lot of information on trauma, head trauma, seizures, shock, and then we've started into shock and burns. What are the things that you need to know about these things so that you can respond in the early and quick onsets of emergent situations? So Christine talked about she's seen people be sweaty, chest pain, and high blood pressure, right? Heart attack. That's what we're starting to worry about. What other things have you guys seen in your facilities that you started to worry about?
We had a gentleman, he had his leg amputated below the knee.
Okay.
And so we started to, they sent him back quicker than we thought he was going to come back. So when we went in there, he had like really bad fatigue, chills. His blood pressure was usually pretty high, and his blood pressure was running super, super low. He had a bad temp. So he was also kind of confused more than he was. And so we wanted to send him out because we thought he was like going into septic shock, but then the doctor said that he wasn't. And so the infection basically spread more, which had to get his other leg amputated. So
Okay. So we started with, you said, a below knee amputation?
the below knee.
Below knee amputation, right? So that's what we started with. But the below knee amputation's not the issue, right? Below knee amputation is not the issue. It's the fatigue, chills, and temp that we're starting to see. The low blood pressure. What criteria does that fall into?
Infections, basically, like criteria, like infection wise, or
It's the SIRS criteria. If you guys watch that music video that I sent out, every single one of those is in the SIRS criteria. Okay? And when we have patients at the hospitals and at the facilities, we're constantly doing that criteria. We're constantly looking. If nurses chart on that every 12 hours, where are you in the sepsis protocol? Okay? Because septic shock is actually one of the most deadly types of shock. Okay? Because, what?
So Amber is still saying that she said that she's trying to put the password in and says it's the wrong password.
Did she do what was in the announcement today?
Yeah, I actually asked her the same thing, and Lexi is also saying that it's not working with her either.
Okay. I don't know how to get her in without, I don't know why Zoom does this.
I couldn't get in because I kept putting the password in without a capital S and then the word. I had to put like capital S and then like the rest of the word shock.
Okay. So Nav, if you want to let her know to do a capital. Or if someone, I know this isn't ideal, but if someone wants to put her on speakerphone at their place, then she can listen and then she can watch the video later. I don't know if the video necessarily helps that much. So, because this is being recorded, so hopefully, where's my output? Okay, so, okay, so we're talking about emergent situations that we've seen in our facilities. So this bad boy, this is all sepsis. Okay. Things that we miss with sepsis is we miss the change in vital signs, right? So you talked about that he had a low blood pressure. Okay. We miss that a lot of times because we're like, oh, their blood pressure's better. You know, usually they run 140s, 160s, whatever, and you're like, oh, they're 120s. Their blood pressure's better. Blood pressure's not better. Something's going on. Okay. It could be that now, what if your person was given low pressure? That can mask it, right? What if your patient was given Tylenol or Percocet? Right? Those chills and temperature, that can all mask it. And that's why it's really important for us to pay attention. What if your person was given Percocet? Okay, so now the Percocet pretty much counts for all of that stuff. All the side effects with Percocet: decreased blood pressure, sleepiness, confusion, temperature, right? It'll take care of all of that stuff. It won't really take care of the chills. Okay, although sometimes people with narcotics can get it like a tingly feeling. So that could be described sometimes as chills. All right. So that's something to think about. Like when we're, what, who's got the Wheaties? When we're thinking about taking care of these patients, we also have to think about what medications we've given them. Okay. But any of these things that are chronically, that we're seeing like over the 12 hours, their blood pressure was 120s. I gave them their nighttime pills. And at 3 in the morning, I went in. What things like my doorway assessment would say something else is wrong? Okay, it's that change. And what you're looking for is a change. That is still increased confusion. I gave Percocet at 10 o'clock at night, and at 6 in the morning, we're still confused, and we're still sweaty, and we're still, complaining of more pain in that leg, even though that was not the, the amputation's been done and they've been fine for a long time or whatever. Okay. Sepsis is a huge one. Heart attack, that's going to lead us to cardiogenic shock. Okay. Heart attack, cardiogenic shock, something's wrong with the pump's not perfusing. Okay. So that's something to think about as you're going into, heart attack's bad enough, but heart attack then leads to cardiogenic shock, which then causes other problems. So think about the signs and symptoms of heart attacks. Some of them we miss. Some of them we don't pay attention to. Okay. What other kinds of situations have you guys had in your facilities that you ended up sending a patient out for?
So I had a patient, I wasn't there that shift, but they sent a patient for bowel obstruction. He was complaining a lot of like pain, and he didn't have a bowel movement for a long time, but somehow the nurses did not send him to the hospital, and I think he had they had to do surgery on him because the nurses did not send him on time.
Okay, so I don't know if you guys have ever had to potty train a kid, but there's a book out there called Everybody Poops. Okay, I should go find it and bring it down. It's called Everybody Poops. It's a really funny book. It's about elephants poop, mouses poop, everybody poops. Problem is if we don't poop, we have big problems. And we've kind of already talked about that with the blockage unit, but if we don't poop, what happens? Come on, guys, we already gone through this. What happens if we don't poop?
If you get a
Also gonna get backed up.
Okay, so we're gonna get stopped up. Okay, then what happens?
Constipation.
Oh, that constipation's kind of already happened here. What happens? What happens to the bowel?
You get necrotic bowel from it.
Okay, so we start to get
Lose that like blood.
and then decreased perfusion. And if we get dilated bowel and decreased perfusion to it, so that bowel turns into a balloon. What happens when a balloon gets blown up and keeps getting blown up and keeps getting blown up?
It's gonna pop.
It pops, okay? So if poop causes our bowels to pop, then what are we worried about?
That ulcer, hernia or ulcer or infection. I don't know.
septic shock.
Septic shock. Why are we waiting for septic shock?
Because that bacteria is going everywhere. From the poop.
Yeah, all that poop that was way back here is now all in that peritoneal cavity. Okay, so your peritoneal cavity has poo all in it now, and it is gonna cause what we call peritonitis, which if you've got peritonitis, like more people died from the Civil War because of peritonitis than died because of their initial injuries. All right. And that was because they would get shot, they'd get gut shot, and all that bacteria would build up in there and they would go septic. So you get peritonitis, right? Which if you break that down, inflammation, infection in the peritoneal cavity, and now they're septic. Okay, and what do we do for patients that are septic?
They get loaded up on antibiotics.
Okay, so antibiotics. What else do we do? Oh, good, Amber got in. What else do we do? So we're gonna slam them with antibiotics. Before we do those antibiotics, what do we want to do? I see Christine mouthing something, but I don't know if she's actually talking to me or someone else.
Would you do like IV fluids on them?
Okay. IV fluids. But what do we want to do before we start slamming somebody? What is the purpose of antibiotics?
Kill the bacteria.
To kill bacteria. So what do I want to do before I get those antibiotics on board?
Labs.
Which labs?
Culture and sensitivity.
And cultures.
Yeah, we want to do blood cultures. Now, this gets really hard because if you're having to call lab to come get your blood cultures, right? And you have the antibiotic sitting in your hand and you have a patient dying in front of you, what are you going to do?
Don't you start it?
Yeah, it really sucks and we get yelled at. But if I have the antibiotic sitting in my hand and I've got a patient that's starting to crump on me in front of me because they need their antibiotic, we need to start killing this bacteria, we've got a problem. Okay?
Why do they get mad? Is it because
What?
you could be given the wrong? Do they get mad because you could be given the wrong antibiotic, or like what would they be mad about?
They're mad about because what's that antibiotic gonna do?
Say it again.
What's that antibiotic gonna do?
It's going to kill the bacteria.
Right. So when you do that blood culture, you won't know which antibiotic that you need.
Right.
You need the blood culture so you can see what bacteria is growing, so you know which antibiotic to use. But when we start antibiotics, when we start throwing antibiotics at people, we're throwing Vanc, we're throwing Zosyn, we're throwing we're Vosin or whatever I think on the East Coast they use. Like we throw broad spectrum antibiotics at you until we can get it down. Okay? I'm serious, guys. If you watch that music video, all of this is in there. Okay? Like Rachel, I had her listen to it yesterday and she's like, oh my God, that's so good. It's so in there. Okay? Getting some antibiotics in. But talking like IV fluid, we're not talking like a little bit. We're not talking like these little, 100 ml bags that I've got.
Liter bags.
We're talking liters of fluid. Okay? Why is sepsis such an issue?
Because it's in the blood.
Okay, because it's in the blood. So why push it further? Why does that make that an issue?
Because it spreads out through the body quick.
Right. It's in the blood. It's everywhere.
Yeah.
Okay. If you think about your blood vessels, right? Okay. Think about your blood vessels. They're everywhere. But if you think about bacteria aren't these nice.
It's poking holes through the.
Yeah. Bacteria are like. Okay. They're those like spiky ball things, and they're gonna bounce around and poke holes as they go through. Okay, so septic shock becomes a big issue because it becomes a systemic problem. Hemorrhagic shock, usually you have one area of bleeding that you can put pressure on and hold some time. Okay, cardiogenic shock, that's a problem directly with your pump. Hypovolemic shock, you have to figure out why they are. Neurogenic shock, we know we have a spinal cord injury. Okay, but septic shock, it's all throughout that body. All shocks kill people. Okay, people die from shock. But septic shock is everywhere. And think of all the infections you guys have taken care of this semester or while you're being in clinical. I am betting every single one of you guys has had some sort of patient that had an infection. Okay? So that's why this becomes such an issue, is because it's so common. Think of the things that cause infection. We've done a lot of talking about washing hands and safety and sterile gloving and all that kind of stuff. Think about all the things that we've taught you to do that cause infection. So that's why septic shock is a really big deal. And that's why hospitals work really hard to keep people from becoming it. But what I find is that people in long-term care facilities or in rehabs, they sit on them and they sit on them and they sit on them. And you have a patient that's having increased confusion, decreasing blood pressure. I had a patient that came in one time, the facility, well, and this one was even just so backwards. So the facility had sat on him for like 3 days. They sent him to their small town hospital. Small town hospital kept him till Friday night. And then they didn't want to deal with him anymore. And then they shipped him to us and he was dead by Tuesday morning because they sat on him too long. And then they didn't recognize those simple signs, those simple changes, okay, of going in the room and saying, hey, something doesn't look right. I'm going to dig a little deeper. I'm going to figure out what's not right. So septic shock is a really challenging one for us to get in. And then if we put in volume too fast, we overload them and we cause all sorts of problems. But if we don't keep their pressure up, we can't perfuse kidneys. Okay, so that's why when we start getting into these emergent situations, we start really watching our kidneys. They become very, very important for us to make sure that we've got the adequate volume in them. So, okay. Let's see. So septic shock, one of blood cultures, along with other IV, what other lab values are we gonna do on a shock patient in general?
White blood cell count.
Okay. Yeah, I want a white blood cell count. Okay. I don't know if you guys saw lactate. Why are lactates important for shock patients?
Doesn't that have to do with something with healing?
No, that's your albumin.
Okay.
Yeah, but we definitely need albumin after.
Lactose? Oh, I don't know. Lactate.
What about a metabolic panel though, Erin?
You could, yeah, depending on what they're going into. I might want to see on a CMP, right? Because I want their renal numbers.
Yeah, especially if they became septic from like a UTI or something.
Oh, good call. So what else might you want if they got septic from a UTI?
A UA.
Yeah. I want a UA. On any person that has new onset confusion, I want that UA. What is one of the first signs and symptoms of a UTI?
Would you want a UA on it? Like, would you be like, oh, they're confused, I need a UA on a younger patient, or would you just want that for an older patient?
Definitely an older one. A younger one, if they're having new onset confusion, I'm usually looking for what do we worry about with younger people with new onset confusion?
Maybe like a brain injury?
Well, that or like hypoxia. Like
Okay.
if younger people are kind of different, we show things a little differently. If we have new onset confusion, it's usually going to be a hypoxic. Just like with little kids, they don't usually have cardiac arrest. Older adults have cardiac arrest. Kids have respiratory arrest that turns into a cardiac arrest. That's why with little kids, you do a lot of times you do air first, because they usually have respiratory arrest that then causes their heart to stop. So, but UA, because what is the first sign of a UTI in our older population?
Confusion.
Confusion, right? And confusion doesn't have to be that they're not making sense. Confusion can be they go into the wrong room. You know, like they're tootling along with their little walker and they're going into the wrong room. Or that they fall. A fall can be a sign of confusion. They were confused and they got out of bed and they were confused how to make their legs work. You know what I mean? Confusion doesn't just have to always be like oh, they said things that were off. Like confusion can be other symptoms. It's that something's not connecting right in the head. And so that should trigger us that we got to do something like, they don't usually fall. I wonder why they fell today. And then just watching them a little bit closer to see, are they making nonsense, or did they trip over their shadow, kind of thing. I mean, we all have bad days where we trip over the moving line in the rug, right? So, but lactate, let's go back to our lactate. What is lactate?
Acid in your blood.
What?
The level of like the lactic acid in your blood.
Yeah, but what does it tell us?
Your pH level.
Nope. pH, you have to actually
Something about if you combine it with oxygen, then it tells you, if you look at the oxygen level, it tells you like the fuel that the brain and your heart has. Is that what it's measuring? Like
Acid.
So it's measuring the lactic acid. Okay.
And that the muscles make, right? Or something like that.
What, Catalina?
Doesn't it, the lactic acid, it like has something to do, like, cause it's made in the muscle.
There you go. Keep going.
Like, is it something about the muscle, and then maybe we're thinking about the heart muscle?
Okay.
You know?
Now remember, septic shock is everywhere.
Okay.
So if I'm worried about just the heart muscle, what labs would I want?
Like cardiac enzymes.
Yeah. You're going to want your troponin, your CK, CKMB. Those are your cardiac markers.
Does it have something to do with metabolism?
It's not so much the metabolism. We're going on the right track with the muscle, just not specific to just cardiac muscle.
Is it just
The liver enzymes?
your whole your body, like your muscular system shutting down?
Okay. Pause, guys. Pause. Okay. Who works out?
It's been a while.
Sometimes, right? Sometimes. Who went out in their garden and the next day they felt sore, right? You were digging in your garden, you did that one, you were a weekend warrior and you went out and did something for the weekend, and the next day or the next 4 days, you feel like you didn't know you had those muscles. You didn't know those muscles existed, because what is built up in them is lactic acid.
Yeah, we had this conversation before, I remember.
There we go. And I'm like, I know I've talked about it, but it goes under the rug sometimes. All right. You are sore because you have lactic acid. Sepsis is all over your body, damaging every muscle in your body. It's damaging every blood vessel that's going to those muscles in your body. Okay, so thinking about that, when we have a lactate that's climbing, that's going up, and we're not talking a lactate because of trauma, because trauma, right, will crush a muscle, and so you'll have a bunch of lactic acid that'll get released because you've damaged that muscle. Lactic acid tells us about a systemic muscle damage. So think about like your triathletes. If you drew their lactic acid after a triathlon, they're probably looking pretty awful, right? I mean, their lactates are probably way high because they did that damage themselves. But if you get an 80-year-old that comes in and their lactate is really high, we've got an issue. We have muscle damage. We have damage, systemic damage to the body. Lactic acid, I was told one time by a physician, if you take lactic acid times 10, that's their mortality. So usually we want you less than like 1.5 or less than 2. If we start getting a lactic acid that is up to like 6, they have a 60% chance of dying. Because it's telling you the whole body, the whole muscle system of that body is being damaged. Okay, so that's why we use it. A lactic acid is going to be drawn in an emergency situation. This is not something you are going to draw in your facility. Okay, it has to be on ice and it has to be done quickly. What, Jessica?
Could you use the CK value then if you don't have the lactic acid, or would that not tell you the same thing?
That would tell you at least that there's muscle damage. Yeah, so you could probably do that one. But again, if you're doing like a chest pain panel on someone, you're probably shipping them. Like If you're a person that it gets to work like in a swing bed unit, where you you're a hospital and a rehab, then they kind of swing the bed back and forth depending on the the load of patients and stuff, you might see some of these labs. Or what's really nice is when you get these patients to rehab and you can go back and look at their old lab values and you're like, whoa, they had a lactate of like 8.6. No wonder they're gonna require more rehab than a person that maybe had a lactate of 2, right? Because they had more systemic muscle damage. So it's understanding like what these are telling us. You know, we understand white blood cell. That one's telling us pretty strongly that we've got some issues with infection or inflammation. Something's going on, right? But lactate is telling us that we have systemic muscle damage. The biggest thing is if you get somebody who's been in a burn or an accident, like a car wreck, well, they've had systemic muscle damage, right? The airbag hit their chest, so all of that muscle on the front of their chest is damaged and will have a high lactate level. So they can you have to think about who's messing it up. But that's why lactate level is really important with the sepsis protocol, is because we need to know what's being done. Okay.
Erin,
Yeah.
what do you give to lower the lactate level?
Fluid. You flush it out. You can't heal it. You can't heal it. You flush it out. Your goal with sepsis, you're giving fluids for a couple reasons. You're giving fluids because what's happening to the hoses?
They're just spraying out blood everywhere.
They're not spraying out blood. This isn't
fluid.
hemorrhagic. We're still on sepsis. What's happening to those hoses?
They're leaking.
They're leaking, right? They're the old sock. That's not working anymore. That's not tight. That's not comfy. That's not feels good. These are the stretched out baggy socks that slip down over your feet and they leak stuff out everywhere, right? If your feet were sweating, they're not holding it in, okay? That's what these vessels are. So then we're gonna give you IV fluids to re-put volume back into those vessels. The problem is we didn't fix the holes.
So do we have to give plasma?
We might, depending on how fast they're crashing and how bad they're crashing, we might. It just depends. But you're 4 liters of fluid. So we give it for volume because they're losing volume. So septic shock is actually a type of hypovolemic shock. You're losing volume. It's coming out the teeny tiny holes that are made in the vascular system, okay? The other reason we're giving that is to flush out, to dilute the bacteria, right? We want to flush out that bacteria as much as possible and to flush out any of the toxins. So if you watch the video that's like all nice and scientific, that's like way over the top, but really good information if you pick out the big concepts, we got to flush out all those toxins of the breakdown of all the tissue. So there's kind of a lot of reasons we give a lot of volume. And for this volume, we're probably going to give normal saline. Usually we just slam them with normal saline, okay? And it just depends. But what's this patient going to look like that we just gave 4 liters of fluid to?
Bloated, maybe. They're bloated.
Not bloated, because bloated's more that gas belly, but you're on the right track.
Comfortable to be like,
Right.
like that.
Puffy. Yeah, they get really, really puffy because remember, it's a systemic issue. It's not one space. Like, you know, when we get patients with their generalized edema, that's the blood flow and the lack of fluid being pumped back up. But these guys, they get puffy everywhere because we have given them 4 liters of fluid, okay? Or lots and lots of fluid trying to keep everything going. That's our biggest things with these, is that we've got to keep, and guess what? You cannot fix this until you get them to the hospital. So what I want you to think about is on that music video, I want you guys to go back and watch it. Listen to after we've talked about it now, listen to the lyrics, read them, because I think it posts them across the bottom. And think about the things that you see. How can you prevent this from happening? Because this is what kills people, and we try and keep people alive. Okay, so thinking about our sepsis issues, what do we have to do? How do we take care of these? Okay, lactate becomes really important. UA becomes really important. Blood cultures. The blood cultures in UA, same reason we're doing it, trying to figure out where the source of infection is. Okay, so that's why I think they talk about doing a chest x-ray to see if it's a pneumonia. Are they septic because of a pneumonia? Are they septic because of a perf bowel? We have to figure out why they're septic, because then we have to take care of that issue, right? If they're septic because they have an abscess in their belly, we have to go in and take care of that abscess.
Erin, I have a question.
Yeah?
Okay, so you know how people are like dying from what's going on right now?
Yeah.
Is it because of like sepsis, like pneumonia, or does it have anything to do with that?
They're dying. So they're dying because of from what I'm understanding, they're dying of basically what's called ARDS, which is acute respiratory distress syndrome. And it is like lung failure. So they're dying. A couple, and this is, guys, this is all super new. So if you read in the CDC that something changes tomorrow, that it's very plausible. A couple things that I've heard is, one, that COVID is causing something. We have to think about how okay, you have to think about how our blood cells, they normally like oxygen on them, right? Okay, so our blood cells like oxygen on them. And that's how we get oxygen to our tissues. Well, it sounds like what COVID is doing, one of the things that's doing that's making it so hard for us to oxygenate is that it's sticking to our blood cells and it's blocking off the oxygen receptors. That's why I think we're seeing people come in with, I just listened on the news this morning from a doctor, and he was saying people are coming in with O2 saturations in the 50s. And they're talking, like they're talking to us. He goes, they're clear. He goes, what means is their body has accommodated the slow decline of oxygenation ability. So what do you think this patient looks like if their oxygen isn't getting to where it needs to be?
Blue, purple, or
could be getting some, they could be getting some blue color. What do you think their pulse is doing?
Jumping.
Compensating for it, so it's probably higher.
Yeah, so their heart rate's probably climbing. Heart rate's climbing, okay? Now they're not in shock, so they're not having the blood pressure issue, right? Because their heart rate's elevated, but it's not elevated because of volume issue, it's elevated because of oxygenation issue, okay? The other thing that we're starting to see is then they're having to give them high dose, like high liters of oxygen, okay? So the thing that's going to become really important with this is to be, when we start coming down with this, is to monitor our saturation. And if you're lucky enough to have a Samsung phone, woohoo, Samsung did something right for once over Apple, you can check your pulse ox on your phone. So I check my daughter's pulse ox pretty regularly on my phone. It is a little sensitive and finicky, but you can do it. So he said basically a pulse oximeter is going to become like a thermometer is. So that's one of the things that we're seeing that people are buying from.
For it?
What?
Is there an app you check?
It's just in your health app. It comes on the phone. So, but otherwise, pulse oximeters aren't super expensive. So that's something that we can be watching too, is that people are becoming unoxygenated. Then what's happening is the lungs become stiff and they can't get oxygen through and to them. And so that's one reason why we're seeing the prone, laying people face down is really helping them. Okay.
I saw that.
Yeah. And it's because we have more lung volume in our back. So when we lay people on their back, we fill with fluid back there. And so we actually minimize. So laying them on their stomach actually helps open up all that back lung tissue. And that's really helping people. The other thing that's happening is that then as the respiratory failure continues, the fluid starts shifting into around the alveoli. And then that's when we start having what we call flash pulmonary edema, where the fluid fills all this in. Okay, and so now around your alveoli, instead of being blood vessels and all that, it's now extra fluid. And so we're having then hard time getting oxygen through that fluid, getting that gas exchange piece. So, I mean, there's a lot of pieces that are happening with this virus. That's what makes it not like a normal influenza, but it's also all new. That's one reason why they're thinking blood transfusions are helping people, is because we're doing this. What is something else that is more prevalent that causes something like this?
Pneumonia or
Huh?
I don't know. No.
You mean another disease?
Something. Carbon monoxide poisoning. Carbon monoxide poisoning is this, it does the similar things. Carbon monoxide it likes hemoglobin better than oxygen. So like I didn't talk about it in the burn lecture, but the burn nurses, they take care of carbon monoxide poisoning patients. Let's see if anybody's texting me for.
Would it start with a headache, Erin?
Good. Yeah. Headache, fatigue. That's why it's really important to have carbon monoxide detectors in people's houses, because once this happens, so our oxygen gets kicked off and the carbon monoxide starts kidding on, they look really interesting because they have their gums and their lips get different colored, get really bright red, because all the oxygen is getting pushed off the hemoglobin, and so it's surfacing underneath the tissue. So it's really, really interesting. So they look really different. But again, treatment is get them on high liters of oxygen, trying to literally blow the carbon monoxide off, blood transfusions. So that's why it's really important for us to understand like the pathophysiology that's going on with the disease process. So that way we can understand why our treatments are what they are. Okay. They got to dig down into that patho, because then all of those interventions, they just roll right off of it. Okay. If we say, you know, that UTI is the main cause of sepsis, what interventions are you going to put in for your patients? What kind of interventions do we have to prevent UTIs?
Fluid more frequently, make sure they're wiping correctly.
Okay, so increased urine output, like
increased
the bathroom more often, bathroom
intake.
Clean, like peri-cares.
Yeah. Catheter care normally is the cause of that sometimes.
Okay. Yep.
Increased fluid intake.
Okay, increase that fluid. Right. You guys know all of these interventions, not just because you memorize them, but because you understand where UTIs come from, right? That's what we have to start doing. We have to transition from the memorizing to the understanding, because guess what? You're going to see stuff like this. You're like, oh, this is COVID, but it looks like our carbon monoxide poisoning. So what do we do to treat carbon monoxide poisoning? Let's use the similar interventions. Okay. So, and that's probably a real layman's kind of term. I mean, they're digging down and doing a ton of research on them. But I mean, I know you guys haven't started seeing it really here, but we're going to get it here probably in the next week or two. Is kind of what the hospitals are prepping for. I know the unit that I'm on said we've intubated 6 to 7 patients, and we're a progressive care unit, so we don't usually do that. So it's coming.
Yeah, we have some patients in CCU who are intubated, in addition to the ones that we have up on 5th.
Yeah, so it's coming. It's just a matter of time at this point. So.
I think I have it because I work in Crete, and Crete is a hot spot right now.
Yeah.
And I've been having like cough, really bad headaches. My chest is like really tight. And they're just saying treat it like you would like a respiratory infection.
Yeah. Jen, I would probably go get tested.
Yeah.
So call your doctor, and I would say go get tested, because they need to have better numbers. So, and we have enough tests now. It sounds like we're not really doing a lot of testing here, but
I saw too, like the thing said in Lancaster County, like that number is like not accurate. The
no.
one, it's like 1 or something. I'm like, that's not true.
Right. Well, the other thing is you have to understand, like, Catalina, like you're seeing the hospital, your patients aren't from here. Some of your patients are from outside Lancaster County.
Mm-hmm.
And so then they get counted on their numbers.
Oh, okay.
So that's part of it too, is Lancaster County is a hospital area. I mean, we have 3 hospitals right here that are going to be taking care of these patients, but the patients will count for the county that they live in, not the county they die in.
I still can't believe that there's only 1 in Lincoln though, Lancaster County.
Right. It's like, who, you know, they're not wasting tests on people that have died. Let's just be honest.
Right.
So, I know New York got really hard hit for saying that they added a bunch of numbers to their death count, but those numbers were pretty accurate. I mean, their facilities do stuff like that all the time.
So. I have a friend who works, she used to work at St. E's, and then she ended up moving to Ohio, but now she's a traveler nurse and she traveled to New York, and she just posted the other day from like the roof or like the top of the hospital, and they have like those trailers out there. Yeah. And she was saying that, like, people who think that this isn't real, she was like, those trailers are like for the expired bodies because we don't have any more room. And she's in like Brooklyn, New York, and she was just telling me that like all these people are like really, really, really sick. And she's like, people are just dying left and right where she is.
Yeah, like that's what, we don't want to be the next New York, so stay home. So that's the big thing. The nice thing is that it's got a really good survival rate for people who are younger. It's got, you know, I mean, we've got good medicine. It's if we can keep our facilities from being overrun. You know, that's what we're trying to do. So, all right. So we've talked about septic shock pretty in depth. Let's talk about some hemorrhagic shock. Okay. So what kinds of patients would you guys see that you would think would be at risk for hemorrhagic shock?
Patients with new TBIs from like trauma injuries.
But is that going to be hemorrhagic shock? Or is that going to be hemorrhagic injury?
Like if they have a hemorrhagic, I don't know, wouldn't they be I'm saying if it's like a freshly new head trauma, like wouldn't they be like bleeding?
Depends. Did they just get hit in the head once? I mean,
I'm just like if it's they got hit by a car and they hit their head. I'm saying like would that be in the, like right in the new part of the injury?
So let's talk about the difference between hemorrhagic stroke and hemorrhagic trauma to the brain. That's one spot. When we're talking hemorrhagic shock, you're talking somebody who's been shot, somebody who's been stabbed, okay? Somebody who fell off the cliff, or you could have somebody, we have a lot of farm implement people. I took care of a young guy who fell and, you know, got his, you know, impaled himself on a farm equipment. Okay, so hemorrhagic shock is going to be people that are, trying to think, that are losing a lot of, they're not just losing volume, they're losing blood. So they're losing all of it.
Could it be women that give birth, they could go to hemorrhagic shock?
Sorry, say again.
Women that give birth, they go to hemorrhagic shock.
Okay, so a woman that gives birth can go into hemorrhagic shock. From what?
Excessive bleeding.
Okay, but where? Like, we can't just say excessive bleeding. We have to understand the patho of what's going on. Where is a woman going to bleed after giving birth?
In her vaginal canal. Isn't that why we do like the push?
There you go. Yeah, so not accurate, because I'm not an OB nurse. Okay. So baby comes out, right? If the placenta attached correctly, it attaches up here, right? That's where the placenta should attach, is to the top of the fundus. All right, that's where, like, most of the times it attaches to. This is very muscly, okay, which is good because muscles contract, thereby cutting off the blood to it, okay? So when the baby's born, so baby's out, happy, okay? Baby's out, happy and safe, all right? So we're not worried about baby. Now all we have to do is get this part of the placenta out. That's all that happens. For people who've had babies, usually a lot of times you barely even know this part is happening because you've already pushed out something that's 8 pounds. Pushing out something that's a half a pound is not a big deal, okay? But as your body contracts, it pushes this off, okay? With each contraction, it's kind of pinching off the blood supply to this. Well, what happens is sometimes after this comes out, okay? So we've got you got rid of the placenta. There's a piece left of it. And when there's a piece left of it, the body keeps contracting and you can have people that lose a lot of volume. Other things that cause this issue, people that have precipitous births. And I don't know how to spell this at all. Okay. But precipitous births are people that birth really fast. So that's the person that you love and hate all at the same time because they're like, oh yeah, I don't know what people were complaining about. I had my baby in 2 hours.
My sister had hers in like 30 minutes.
Right. That's a precipitous birth. But if you have a precipitous birth, you gave birth to this really fast. You didn't give it time to contract and squeeze down and cut off all the blood vessels to that. Okay. The other time we have problems with moms losing a lot of blood is if the placenta doesn't attach up here. If it doesn't attach up in that fundus area. Because down here is not muscly. It doesn't contract and squeeze real well, okay? It's the top part that squeezes. That's why when you have contractions, you feel it in your back because it's the whole area is contracting, okay? But down here doesn't have that. And so if you give birth to the baby out and happy, okay? But then this part is attached. So when it finally comes out, these aren't being squeezed, right? Because how do you stop bleeding? Keep it simple. How do you stop bleeding? Just anytime. How do you stop bleeding? Compression.
Compression.
Right? You stop bleeding with compression. Okay? You put pressure on it. If you watched me with my daughter, I did that, right? I said, hey, I need put pressure on the bleeding. Go get help. Okay? I'm going to put compression. Here, you can't put compression. The muscle itself is what's putting compression on the uterus. Okay? So it's really important for us to understand there's a couple reasons why we have moms that bleed. One is that precipitous birth. They give birth super, super fast. And so the body doesn't have time to contract that muscle. Okay. Other things that cause that is if some of it's left in, and that's the people you have to do like a DNC on, right? The intervention is go in, take it out, clean it out, put contraction. So you guys also talked about somebody put on, is that why we do the fundoplication, which is the worst thing that you'll ever do to a mom after they've had a baby, is you take your fist and you like push it in their uterus and you push it down. Yeah. And that's why we also want a uterus to be nice and tight. When you feel it, it should be nice and tight because it's contracting itself down. Okay? So thinking about that, absolutely moms can go hemorrhagic. Absolutely moms can lose so much volume that they go into trouble. Another thing that can cause this is if the RH factor isn't done. Because then you have a blood issue because the baby's blood and mom's blood's crossed and mom wasn't positive. Mom was an RH negative person. And so then you have a whole issue with the blood like crashing together. Like, right? So all the antibodies are freaking out and they're all lysosing each other up. They're like little like antibody ninjas. And so they're just chopping each other up and they lose blood that way. Okay? So that can be a problem. But we have to figure out what are we going to do with these moms? we're going to give him a drug called Methergin, which is one of the worst freaking drugs to ever give anybody, but it's going to cause the uterus to contract fully down. It's like a constant contraction. So it's not fun. They don't like it. Apparently also redheads are at risk for having hemorrhaging after babies. My midwife would always have a bottle of Methergin sitting on the counter ready to go if I needed it. I didn't, thank God, but she always told me she had it ready to go. Huh?
Why is that?
Redheads are just screwy.
Huh.
Yeah, like redheads have some interesting genetic differences. Redhead is an actual mutation.
Yeah.
And so, yeah, we're pretty much screwed. So we get it.
Yeah, you made it this far.
Own it
so
and take
you
it
know
now.
that.
So, but yeah, but I never had it. My sister actually, I think she had to have it because she has the precipitous birth. She has births so fast.
Mm.
Her births were, I think, like anywhere from, I think 2 hours was her one. So yeah, so her uterus didn't ever have time to just contract down.
My neighbor overseas in Bosnia, she actually had hemorrhagic because of the RH factor, because in our place where we're at, there's not really like a big hospital because healthcare over there is a little bit different. So they didn't do enough testing to find out like for the RH. So she was like on a vent for like 2 weeks after she gave birth because she was just totally like out of it. Baby was fine, but she wasn't at all.
Yeah.
So.
Yeah. And it takes a while. Like you guys, these are the worst emergent events. Like I've been at the hospital one time when there was a code on a mom giving birth, and they were trying to keep the mom alive long enough so they could get the baby out. And I mean, you want to talk about like traumatizing experience. They had to cut the baby out in the birth room. They didn't have time to get her to the OR. Like they wanted to get the baby out, and the mom ended up dying because they just couldn't. I think she threw a PE while she was in labor. And it's really hard when people throw PEs like after surgeries and stuff like that. It can be really hard to bring them back. That's just it's hard. So throwing that clot into around the lung tissue so that you can't get blood to and from lungs is really a big issue. Okay. So, but yeah, I don't think she did this. I think hers was because the baby wasn't out yet. So, but those can be some really big emergent issues. But when we're talking about traumas and we're talking about hemorrhagic strokes, hemorrhagic shock, a lot of it is because of something going on. So bullets are kind of an interesting thing. Okay. Bullets are interesting because as they go in the body, they change direction. So like when you have somebody, okay, you have somebody and they get a bullet in them. My markers aren't wanting to work today. It goes in, but then it kind of bounces around on stuff. And so we have a hard time with these guys because the bullets bounce around so much that you can't put pressure on it as easily. All right. And so that's something really important for us to understand, that it looks like you get shot, and you do see people where the bullet, they have an in and an out area, and you have to think about everything that went through. Okay. But typically the bullets go in and then they bounce around and they cause all sorts of damage, especially gunshot wounds to the head. They really bounce around because the skull keeps them in. So they do a lot of damage because they bounce around everywhere. And then we have just different problems. But I want you to think about, what patients do you take care of? Think about in your rehab facilities that would be at risk for hemorrhagic shock.
Anybody from surgery?
Okay. Yeah, anybody from surgery. What if the surgery was
something that was stitched that bust open.
Yeah. So you could have a surgery like my kidneys here. Say a person had like a stent put in here, right? They put a stent in their kidney. What arteries are close to that?
All of them are backed up in there.
Like some really big ones, right? Like your kidneys have a lot of perfusion to them. So if the surgeon goes in, and very unintentionally, but it is a complication, and nicks an artery or nicks some sort of blood supply, all of that blood then starts filling up. And you can have a hemorrhagic shock and not see a drop of blood. Okay? You can have a hemorrhagic shock and not see a drop of blood because our pelvis and our peritoneal cavity can really maintain and hold a lot of that blood volume in there. All right. So what I want you to think about is the patients that you've had over, you can think either at work or in your clinical experiences, what surgeries did you take care of? You know? What
Mostly.
Bypass. I had someone who had a triple bypass.
Okay, triple bypass. What were you saying, Rima?
Mostly people that had cardiac surgeries.
Had cardiac surgeries? Okay.
Yeah.
So if we have somebody with a cardiac surgery, and actually I have a kind of a fun story. I am not a cardiac nurse. I never pretend to be a cardiac nurse. For 5 weeks, I got to be a cardiac nurse, and they were horrible, but I got some cool experiences. But I took care of a guy who, they have tubes in there, right? Because you want to take out the blood as much as possible, like so that it doesn't, just like a JP drain, but they have it in the heart. Okay, and they call them pericardial tubes or pericardial drains. And because he had a CABG surgery, which is that coronary artery bypass graft, had that surgery to reroute from the blockage. And one of the sternal wires, right? Because they have to go in through that sternum. One of the sternal wires had poked into the pericardial sac, which then made it continuously bleed. Okay. How we knew he was in trouble is nothing related to his heart rate or his pressure, but everything related to how he looked. He was intubated, but he would like wake up and be responsive. And then all of a sudden his eyes would roll in the back of his head and he would go unresponsive. And we would strip the pericardial tubes just like you would your JP drains. And all of a sudden he would dump like 500 mLs of blood and he'd wake up. Okay. So understanding the anatomy, you understand that pericardial sac goes around the heart, and with one of those sternal wires poking that sac, this is what was filling with blood. So what was it doing to the heart?
Compressing it.
Yeah, it was, this is where you have that pump issue. Your heart couldn't fill. So every time his heart would pump, more fluid would fill that space around it. And it started what they call a cardiac tamponade. So it starts squeezing down on the heart. So we would strip the tubing just like you would your JP drains, and the blood would flow out and he'd wake up because his heart could then pump again and we could perfuse. So things that you worry about when you get to your hemorrhagic shocks are level of consciousness. Okay, are they awake? If they're not awake, we know we aren't perfusing well enough. Okay, because you, like, let's just be honest, the first thing you're not going to do necessarily is take a pulse. You're going to try and wake someone up. Hey, are you okay? What's going on? Are you can ask if they can respond to you. Ask if they can answer any questions. If they can't, you know you're in trouble. All right. Other things we're going to look at is their color. Okay. And this is where we're starting to go into that big idea of just shock in general. What am I worried about? I'm worried about perfusion, gas exchange, cognition. Those are my 3 things that when I do a doorway assessment, whether it be at the side of my patio or at a playground or in the lunchroom, right? You look and your level of consciousness, color, And then just seeing what's going on. Are they slumped? What's their body position? Are they unconscious? Are they, you know, kind of looking at that whole scene of what's going on around you. All right? Those are going to tell you things first. Those are going to be the things that start triggering you to make you dig. If their breathing is not right. Are they breathing? Are they agonal breathing? What does it look like? Okay? What are you seeing? That's some of the biggest stuff that you want to be looking at. Okay? Is that level of consciousness, their color. What, Jessica?
I have a question. So for this patient, for like the stripping the drain thing, was that just something that you guys did temporary and then fixed it, or did you have to keep doing that? Okay.
No, we had to keep doing it until we could get the surgeon to wake up and come back in at 3 a.m. and take care of it. Yeah. Yep. We're not fixing that. As long as that wire's poking into that pericardial tissue, it's just going to continue to bleed. So yeah, we finally called in the doctor. He was not real happy with us. We're like, something's wrong.
Yeah.
You know, and this is where, like, how would I communicate with that doctor? Because I'm not going to be like, you know, hey, his blood pressure's fine, his urine output's fine. No, I'm going to be like, hey.
Focused phone call.
Yep, it's going to be very focused. Hey, every 5 or 10 minutes, he is going unresponsive and unconscious. As soon as we strip that his pericardial tubes, he's draining 500 mLs of blood. Something's not right. And the doctor's like, oh. So then he comes in and he's like, yeah, there's a pericardial. And we didn't know what was going on, right? We just knew these things were changing.
Yeah.
Every 5 to 20 minutes, depending on how fast it would feel. Poor guy. I felt so bad for him. But yeah, he was really sweet when he finally came off the ventilator. But if he had been sedated, we may have missed it, right? We may have missed that, because what was our biggest key was that level of consciousness. He should have been coming off the ventilator. Usually we do a cabbage. I think they keep them on like the vent overnight, but they titrate off the sedation so that they're waking up. And he would wake up and then go out and wake up and go out without any sedation. So we knew there was something going on. So, but other things that would trigger us, his heart rate would probably start going up. Blood pressure is probably gonna start tanking if we hadn't kept stripping. So yeah, as a nursing student, I'm in there just stripping pericardial tubes, and I'm like, please don't pull it out, please don't pull it out, please don't pull it out. Okay, so, and we gave him lots of volume afterwards. We gave him lots of blood replacement and stuff to bring him back up. The nice thing about hemorrhagic stroke is if we can find the source of bleeding, we can stop it and we can get there. I had a patient one time, so think about your wound vacs, right? You've got a wound vac on someone. Well, wound vacs suck. Literally, that's what they do. They suck. And so I had a guy who had a wound vac, and he'd had his hip socket taken out because he'd unfortunately been rolled over by a camper. And we ended up, I looked at his wound vac and I'm like, the canister's full. Well, we have the 500 ml canisters, you know? And I'm like, that's full. So I went and I changed it, and then it was full again in like less than 2 minutes. And I'm like, something's wrong. My patient looked the same. He was sedated and on a ventilator, and his pressure and his vital signs were the same. But what was different was his canister kept filling up. And so I had to call the doctor, and I called him and I said, something's wrong. The canister keeps filling up. And so he's like, okay, he comes in with his Birkenstocks on and jeans, and just puts on clean gloves and starts tearing down this wound vac. And he puts his fingers right on the femoral artery and says, we need an OR and we need it now. And they did surgery. They ended up getting him down to OR very, very quickly. But I mean, it was not a sterile procedure because we couldn't be. Like, you had, in order to save his life, they didn't have time to sterile glove, right? Because if that surgeon took his finger off that artery, he would have been gone. Like, you can bleed out of the femoral artery in 3 minutes. So, yeah, he ended up, well, he didn't end up living. He died of massive septic shock. Why did he die of septic shock?
From that bleeding out.
No, not from bleeding out. But why did he die of?
It was unsterile.
Nope.
From the artery.
Nope. Because a camper had rolled over him. think of all the germs that are on the road. That had rolled over his groin and his leg and rolled over pretty much the internal, like the pelvis area, and think of all the internal organs. So basically he died of like a peritonitis. He died of an infection got into that internal cavity, and there was no saving him. And this can be really, really hard for families, because they'll be like, oh, well, he made it through surgery. He made it through surgery, he's fine. And I'm like, 7 to 10 days. Sepsis can take 7 to 10 days to set in. That's how long bacteria grows. And so, and can overwhelm the body. So it took him,
I'm sorry, something like that, would you just automatically know to start him off on antibiotics? So,
oh yeah. Yeah, he's one you're dumping, because you think about you think about the road. Like anybody I've taken care of so far that has had significant injury where they've gotten dirt like from the road, like drug on the road, or and we're not talking like road rash where the skin is still intact. That's more of like a burn. Okay, we're talking people that like open down to the core tissues and exposed to the road. The road's dirty. Like it's just gross. You know, I mean, that's why when you skin your knee, or your kid skins their knee, rollerblading or whatever, you wash it right away, because you've got to get those germs out. So he, unfortunately, he didn't make it, but he didn't make it because of sepsis.
Erin.
Yeah.
So I've been like, I think of the road as clean because the sun, I think the sun kills the germs.
Nope,
on the
sure
surface.
doesn't. Like I'm a mom that's like, rub some dirt in it, you'll feel better. Like that's the kind of mom I am. So my kids usually have to be really broken before we go to the hospital or go anywhere, as evidenced by days of waiting for broken arms. But like, yeah, dirt is not clean. There's just so much bacteria and stuff, and there's so many cracks and crevices in the cement. And like he also had a tire from that then rolled over him too. So he got a lot of bacteria in his body that we couldn't get enough out. I mean, they flushed and they washed his entire peritoneal cavity. And there's just not enough. Okay. So when we're talking about any kind of shock, we're really focusing in on, you walk in that room and something's wrong. Something's different. So there's a change. I don't care what that change is necessarily, but there's a change that triggers you to be like, hey, I need to keep digging. And this is where we're going to start going. This is that nursing intuition. And it was kind of cool. The Mayo Clinic actually did a research study on nursing intuition that looked at like nurses can catch things before the numbers change. Right? Nurses are like, hey, something on this is saying that this is not right, or there's an issue. And that's what this is. This is what nurses see. We recognize patterns, and we start seeing that there's a change in a pattern, so that all of a sudden they're having confusion. All of a sudden they're having pain where they didn't have pain before. Okay? Because like a person that has bleeding internally, their pain is going to be like lower back. And in the pelvis area, they're going to be like, gosh, there's a burning or a pain, and they're not going to feel good. Okay. I can't remember. There was someone that we had a patient that I think was having like GI bleed issues and was having a lot of discomfort in her back. And it's because that's where she was bleeding. That's where the blood was pooling. Blood in your vascular system feels great. Blood in not your vascular system doesn't feel good. Like it hurts, it burns, it's just not meant to be there. Okay. So that's something we'll see that change, whether it be pain or discomfort or breathing or level of consciousness. All of that we're gonna see. Okay.
Hey Erin, I have a question. So for that gunshot, the victim we were talking about in the last example, did they have hemorrhagic and neurogenic shock if it was a gunshot wound, or is that
they could
classify it as under one? Could it be both?
Nope, we don't really. I mean, when they die, we have to classify it under one, but we don't really care for treatment. Yeah. We We just want to save their life. So you could have it as a neurogenic if their bullet hit their spine.
Okay.
But then you have to treat two pieces, right? Then we have to get increased volume and we have to decrease swelling in that spinal cord.
Yeah, that's what I was gonna say. So do you just treat it as a neurogenic because that's a vital organ, or do you still have to do both?
You gotta do both, because if you don't have blood and pressure, you can't save them.
Yeah.
That's why, like, me asking which shock is the worst, there's really not a right answer. Kind of depends on what's going on with your patient and where you're at.
Right.
So, but if you're neurogenic, if you have neurogenic shock, you may have to do CPR on that person because their spine is like not able, the nerves can't communicate. That communication has been blocked. So everything below can't talk to everything on top.
Right.
And so you might have to do like CPR on them until you can get help.
Okay.
But their heart might be fine, you know, so it just really, really depends on what caused a neurogenic shock.
Okay.
Because, yeah, but you're definitely, like that person, you're going to want to slam them with steroids and volume. Okay? Because you're going to want to take care of that neurogenic shock. You're going to want to take care of that swelling in the spinal cord and the volume that they're losing. Because it doesn't matter if you're pumping if there's nothing to pump.
Okay.
Good.
Ooh.
So our big thing, like when we're talking about this level of conscious color breathing change, our main areas that we want to do, like think about you guys that have worked home health, or if you work at a facility, right? You've got to get them out of there. You can't, like I've heard a lot of you guys say, you know, we transferred them out. Right, because you don't have the level to fix them, but you can stabilize them, okay? And how we stabilize is we understand we have to get the volume to the brain, the heart, and the lungs, okay? That's the three areas we care about. I don't care about your kidneys. I don't care about your bowel. I don't care about your toes. People lose fingers and toes when they're in shock. We can't get them back. We can't restore the blood flow to them. We don't care, okay? What we care about is we've got to get this. So you've got somebody in shock, and what I'm going to do is I'm going to find a way to get their legs up, because I want all the blood from those thighs and legs. I want all that blood to this space. Okay, and that's why you'll see people be like in Trendelenburg on the bed, right? We'll put their heads down, okay? If your bed can do that, great. If they're on the floor and you can't move them, boogers. We got to figure out something else, okay? So that's something we got to think about, is how do we get the blood from this area to where we want it to be? Okay, and what I'm going to do is I'm going to find a way to get those legs up. I'm going to find a way to get, if it's a hemorrhagic stroke, I'm putting pressure on the wound as much as possible to keep the blood in. Wear gloves if you've got them, or any protective stuff that you've got, but always keep yourself safe. But I'll be honest, there's times where, like, I've been a first responder and I haven't worn gloves. If you're in a facility, you've got gloves right there, grab them. I took care of a little girl one time. I was at my son's my son's swimming and diving practice, and the little girl hit her head on the dive board as she went in. And of course, lifeguards go in, they jump in, they grab her, they bring her out, and she's awake, but she's just bleeding tons from her head, and she's got thick, wet hair, so you can't see what's going on really. And I'm holding C-spine on her. Like, I asked the people, because they needed to go call and do all that stuff, I said, I can hold C-spine. All right, you immediately know somebody's medical if they're using correct terminology. If they're freaking out and saying, what do you need me to do? It's like, go call 911, because you're going to do me no good here. Okay. But I'm like, do you need me to hold C-spine? And they're like, yes. So I held C-spine. I didn't have any gloves on. Her blood is just pouring all over my hands, right? So I'm like, great. So what I ended up doing was, at one point in time, I asked somebody, he was like, is there anything we can do while we waited for the ambulance to get there? And he said, can someone get me a pair of gloves? You know? And so then we ended up like trading out who was holding C-spine, so I could put gloves on and then I could hold it again and they could go do all their stuff they needed to do. So that's ways that you can find ways to keep yourself safe too, when you're dealing with people that are in shock. All right.
So, Erin, did you have time to wash your hands and then put gloves on?
No. So I just was keeping myself from getting at least some exposure. Like I had exposure to the blood that was already on me, but I didn't have time. Like that's my priority. That's my risk that I'm willing to take. Knowing that I'm a healthy adult and I had no cuts on my hands, I'm willing to take that risk. And that she's a 10-year-old little girl, probably doesn't have a whole lot of blood pathogens at this point. She might.
You just dipped your hands in the pool.
Yeah, I mean, I may have like wiped them off on a towel real quick and been like, you know, got them whatever. But yeah, I didn't go and wash them. So, you know, yeah, but at least I wasn't getting any more blood exposure than I already had. So, sweet little girl, poor little thing. I was like, you're gonna have a really good story for this summer. So, about ambulances and hot firefighters. So, but so that's our main thing. When we're dealing with shock, we want to fix, but we have to, the ultimate goal is to correct the problem. Okay? Our ultimate goal is to correct the problem. So if it's sepsis, we have to get them antibiotic. We have to get rid of the infection. We have to do whatever it is to correct the problem. That's our ultimate goal of anybody in shock. If they're bleeding out, we have to stop the bleed. We have to fix it. Okay? That's our ultimate goal. But for you guys working in rehabs and stuff, your goal is different. Your goal is not to correct it. Your goal is to get them to where they can be to correct it. Okay? So your goal might be to transfer. And that's fine. All right? Your goal is still to get it corrected. You just know your limits. I know my limits. I can do CPR for 2 minutes and then I need to take a break. I know my limits, okay? You've got to get them to where they need to be. So, what, Jessica?
Non-hemorrhagic shock then. So what would be the goal for that? Do you just give them fluids and stabilize them back up? Or because that's not really, I mean, it's still life-threatening, but not really if you can fix it.
Right. So like if you have, say you have a patient, so hypovolemic shock. What patients do you think are at risk for that?
Deserts. Maybe.
Deserts, definitely. People that like to do the like adventure hiking or something like that, they're definitely going to be more at risk for it. Your dialysis patients, right? They're going in 3 hours, you are taking off how many kilograms of fluid, you know, which equals how much volume. So it's like, you know, they'll be like, oh, we took off 3 liters. If you took off 3 liters of me, I would be dead. Okay? I mean, I don't have enough volume to balance that. You go into a hypovolemic shock. So what things did they look for when they were doing dialysis? What do you think?
They do saline with that? You know
They do have saline. They can, right? Because that's what they're doing. They end up correcting it by pumping more volume in. But where's that middle ground? What are they looking for? What do they keep watching?
I don't know. There were too many numbers. I don't really remember. The machine was doing a lot of things.
Keep it simple. What are they looking for?
Oh.
Right? They're looking for changes. So all of a sudden they get crampy, right? Mm-hmm. Because they've lost too much calcium.
There was
all
a guy
that their blood pressure.
They were freaking out. He kept like shaking and they were just like, okay, is that normal? Like, why is he doing that? So
right. They're looking for that change. And especially they're lucky enough to have like patients repeatedly, like they have them 3 times a week. So they get to know their routines. They're looking for a change, right? They're looking for a drop in blood pressure. They're looking for all of a sudden they get really pale, you know, because maybe they had a cold this week, so they didn't eat or drink that much, but they have orders to take off 3 liters every time they come in. Well, maybe they had the flu, or maybe they had something where they didn't really drink, or maybe they were out working in their garden, so they sweated a lot, so they don't have quite the volume. And all of a sudden they come in and they take off 3 liters, and now you have a patient with low blood pressure, increased heart rate, and they are not acting right. They're pale, or they're sleepy or fatigued or whatever. Like, it's those changes that we're looking for, okay? That low blood pressure. I mean, if you have the ability to take people's heart rates and blood pressures, do it. But you're looking at that whole low blood pressure, elevated heart rate. Okay, those are really key symbols that something's going on.
Hey, Erin, I have a question.
Yeah.
So, neurogenic shock.
Yeah.
One of the things we'll notice is like maybe limited movement to like lower limbs or like upper limbs.
Yeah. So neurogenic shock is kind of weird. I've only seen it maybe a couple of times, and that's usually a car wreck or something that came in. And yeah, like they can't feel their legs. And so usually there's some sort of spinal cord injury if they're awake. Like if it's been a trauma, they're not awake. Okay. So that's something to think about. You know, they may have gotten hit, and that's the people you hold C-spine on because you don't know what's going on, right? And so, sorry, my son is running back and forth and upstairs, and all I hear is thud, 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 thud. Apparently my instructions of not going running this morning were not heard. But so things that we think about with neurogenic shock, I wouldn't necessarily want to lift legs on somebody that has neurogenic shock unless they're starting to crash and code on me. Then I'm going to do, not having movement of their legs is way better than not being alive, right? That's the principle we care with. Whether that's their choices or not, they didn't have a DNR or DNI or any of that signed, so we are full go. Okay, and DNR and DNIs don't mean to not treat. So you can still have somebody who's a DNR, and if they go into hemorrhagic shock, we're going to give them blood. Okay, because it doesn't mean don't treat. It just means they don't necessarily want to be coded if their heart should stop. Okay, and then it gets really wonky, like Catalina brought up surgery or post-op patients. They give up that DNR. When you get surgery, you give up that DNR for, I think, anywhere from 24 to 48 hours. So you get coded after surgery. Just so people are aware. Like, they may have been DNR when they went into the hospital, and then they came back to your facility and they didn't have their DNR anymore, and that's just because it got lifted and then never reinstated. So just make sure you're asking. But does that kind of help with some of the shock stuff? Shock's kind of fun. I mean, your basic thing is you're going to treat the change, but then we have to correct the cause.
Right. I guess I just don't really understand, like, I guess like hemorrhagic, non-hemorrhagic, and then hypovolemic and neurogenic makes sense, but like distributive is kind of just like, what is the difference with that? Like what?
So what are types of distributive shock? Is distributive the problem with the pump?
Like leaky blood vessels or something?
So that's all sepsis.
Okay.
Okay. Because you're not distributing, think about those blood vessels. You're not distributing the blood and the oxygen to where it needs to be.
Yeah.
It's leaking into the tissues.
I guess like anaphylactic and, well, neurogenic, that would be the, okay.
So, yeah. That's why, like, I keep it in my head. Because I think when I watch that video, I'm like, okay, this is good information. It's either a problem with the pump or a problem with the hose. And to figure out which problem it has will help you figure out what you need to do. Because the other thing is like, if we have somebody who's septic, we're going to start them on pressors because we need to start contracting those blood vessels, right? That stretched out holy sock is not going to do you a whole lot of good. You need to compress it and make a nice sock again, okay? And unlike socks, we throw them away and get a new pair. Our vessels, we can't really throw them away and get new ones. We have to make the ones we have work and refix themselves. So, okay.
Question.
Yeah.
Because I kind of came in right when you were like finishing up talking about. Let me see what did I write. The cardiogenic shock.
Mm-hmm.
So that's basically a heart attack.
Yep.
Okay.
Yep. Because cardiogenic shock a lot of times is a problem with the pump. Something's wrong with the pump. You got to fix the pump. If you don't fix the pump, you can't fix it. So, but something to think about as you guys are studying this, what are some, so you have to go back to your blockage unit. Like this unit is going to bring everything, should bring everything back, right? UTIs. Well, you guys have learned about infections, okay? Blockages. We talked about peritonitis and what it causes. We've talked about heart attacks. Strokes usually don't cause too much of a shock issue. So the blockage to the brain isn't going to be one I necessarily worry about with shock. It's going to be other emergence, that I worry about. Now, when somebody has a change of level of consciousness, I have to rule out, is it stroke or is it cough? Okay, or is it heart attack, or is it hypoxia, or is it that they got too much Ativan last night and it's still in their system? Welcome to being a nurse.
I feel like that's
This
the
is
problem. Like, it could be anything. So it's just
Right?
like, how do you just pick one answer out of, you know what I mean?
Well, that's where you dig. That's that digging. That's that when you go in, what's that important information? What information it needs to go in that core piece, and then what am I really worried about? How do I prioritize it?
It's like that exam question where we had to do CPR, and one of the choices was, do you put them on the floor or do you start CPR? Well, obviously, I'm going to do CPR on the floor. So is that the most important thing? It's just,
Yep.
I don't know.
Yep, you had to put them on the floor because you can't shock a person. Can't shock a person in a
But
wheelchair.
in my head, I was like, they're going to be on the floor. So why is that even an option, you know? So
wheelchair, that's why.
That's because they were in the wheelchair still. Like, yeah, in your head, you've already skipped that step.
Yeah.
But NCLEX doesn't skip that step. So you have to make sure if there's an answer like, oh yeah, I need to get them on the floor first, you know? So yeah, yep. Let's see, I think we've kind of covered shock pretty well. Again, you understand what?
I had a question, but it wasn't about shock.
Okay, what's your question?
It was like about the burn calculation.
Perfect, let's go for it. All right. So, while Catalina's looking at her question, what kind of shock is burn?
Fluid volume loss
Like
shock.
hypovolemic.
Hypovolemic shock.
Yep, they've lost volume. Not necessarily blood, right? They're not bleeding into their tissue. They're losing volume. Okay. So with burn, because burn is a systemic injury, right? Our organ is covering our whole body. The burn is our body has a systemic reaction. It can have a localized reaction, right? You swell in one area, but it can be very systemic as well, depending on how big your burn is. Okay, Kathleen, what's your question?
So like the equation.
Yeah.
Like I just wanted to know if we could do like an example of one.
Yeah, so let's see. We've got total body surface area percent times kilograms times 2 mL. When do we use 4?
when do we use that?
When do we use 4 mLs?
Oh wait, we just talked about it, didn't we? We use 4 ml when it's like a septic shock, fluid flush out.
Nope, because we're not talking about burns. We're not talking about shock.
The fluid flush out? No, never mind.
When it's an electrical burn. When it's an electrical burn, you'll use 4 mLs in your calculation because electrical burns don't have as much surface area. Okay, so an electrical burn does the damage, but if I get electrocuted, and I'll try and do this, in this hand, but I can't lift my foot that high, but my left foot is the one that has the ground, or it has the out wound. Like your burn for an electrical injury is all the way through all of this, but all you see damaged is this hand and my foot. Okay, that's all there will be externally for you to see.
It's like an entry point and an exit point, right? Yeah. When like light, it's got to come in, it's got to go out somewhere.
Yeah.
Our neighbor was in an automobile accident, and they made it through the accident, but I guess there was a live wire in a puddle.
Oh, no.
And so he gets out of the car and into the puddle, and it went in through the bottom of his foot, but out the back of his head. But he lost his legs, but he was still able to function.
Oh, wow. Yeah, that's...
And I learned it has an exit and an entry.
Electricity always has to have a ground. And so it's where is it going out? Like it can't just keep in there. And so that's why with any calculations, normal burns, we're going to do 2 mLs. Kids are a little different. I'm not doing kids. Okay, because you guys don't do IV fluids on kids. Just know that their calculation will be a little different. Okay, so we've got... So say we have a 60% burn area, right? So they've burned 60% of their body. And remember, when we're calculating this, this is also not which type of burn. What burn area do we count?
Chest. Are you talking about like the rules of 9 stuff? Is that what
Rules
you're
of
talking about?
9, but what do we count? What do we count as in the rules of 9? What type of burns what area of burn do we count?
Like, are you talking like anterior, posterior? Like
No,
they're
talking
No,
about,
not superficial.
there you go.
Okay.
None of this is the superficial stuff. This is all gonna be the partial or full. So you don't do fluid resuscitation for a sunburn, right? Because that's all superficial. You only do fluid resuscitation for people who have partial or full thickness. Okay, so we've got 60% that's counted. I did 65 kilograms, so that's how much they weigh, and then times 2. All right, so give me what does all that equal?
7,800.
What?
7,800.
Sorry, my volume's kind of low on my computer today.
Oh.
7,800. So now, how much? That's 7 liters, almost 8 liters of fluid, guys. If we slammed that in them, we would kill them with fluid volume overload, right? And our goal with burns, our biggest goal with burns is perfusion and healing. The reason we give volume is because they're in a hypovolemic state, because they're third spacing all of that fluid into the tissue. If we give too much too fast, we actually almost, we give too much fluid, it causes the perfusion to not work, right? Because we've got too much volume in there, so then they can't pump blood and oxygen to the areas that need the healing. If you do too much, you can convert a partial thickness burn to a full thickness burn by giving too much volume too fast.
But what, Erin, I have a quick question.
Yeah.
Like, what is considered too fast? Because aren't they supposed to have like the total volume of fluid within 24 hours?
Right. Perfect. So this is in 24 hours. But how much of it is in the first 8?
In the first 8, that's where you're going to
Half of it.
Half
Yeah.
of it. Yep. So
Half
you do
of
your,
it.
so your half of your volume is in
And then,
first 8,
yeah.
and then the other half of it is in the
In
next 16 hours.
16 hours, yeah.
Right? So you're gonna see large volumes. And then what is the one thing we use to titrate this? What do you think? What's the one thing that's gonna tell us whether they are getting enough adequate fluid or not?
Patient response.
Output.
Output.
Urine output. So this, guys, is a guideline. This calculation is a guideline. This is the one that St. E's uses. That's why I teach it. The one in your book is like 7 years old and it's outdated. And the book just seems to not be able to get rid of it. So I've been battling this now for 6 years. And it's like, come on, get it out of the book. But this is the one they do. But their urine output is what they're going to use to titrate. So you're going to get them started. And remember, you're going to get them shipped to where they need to be, right? You're not going to keep this patient in your facility if you can get them to where they need to be. Get them to the burn center. Okay, but so for the calculation, we've got 7,800 mLs that need to be given in 24 hours. So we're going to take that to get this, we're going to take 7,800, oh wait a minute. Let's divide it in half. Okay, so in half, it's 487, oh no. I have my calculation next to me, so I have it. So half of it is 3,900, okay? So that's half the volume. So we're gonna give half of it in 16 hours, half of it in 8 hours. Now what do you set your pump to?
488 milliliters per hour.
Yep, 488. Because remember, our pumps are mLs per hour. Literally, all you do is take it, divide it by 8. Because it's going to go over 8 hours, so I divide it over 8 hours. Okay, that's a lot of volume. that is, you know, half a liter an hour. All right. So that's something you're going to pay attention to as you're going through. This one obviously is going to be less than that. It's going to be, so it'd be 3,900 divided by 16 hours. So what's that one?
244.
Oh, 244 if we round it.
Yep. 10 miles an hour. That's what you set your pump to. Okay. So it's just understanding. And what kind of fluid is this?
Lactated ringers.
Lactated ringers.
Yep, this is LR. Normal saline for our septic patients and those ones, and we'll see other fluids. We'll Normasol, we'll throw other fluids on them, but these guys we're gonna do LR. Okay, so that's really important for us to understand. This is the partial and full, and you can convert a burn. I don't know. You can have like a full thickness in one little spot, right? And this is going to be white and leathery and look like if you've ever cooked chicken on the grill, that's what it's going to look like, okay? And when you feel it, it's going to be hard, all right? And then you're going to have the partial thickness. So this is where the blisters are, okay? And then you're going to have a big area that's superficial, and that's where it's red and hurts and is uncomfortable and all that kind of stuff, okay? These two areas are very painful. This area doesn't hurt. So when you have a patient that comes in and says, oh, it doesn't hurt that bad. I mean, it hurts out here on these edges, but you know, this part must not be bad because it must not be burned. You're like, oh, no, that's really, okay. You can't fix this. They have to go to a facility because you have to go down, you have to get good tissue. So they'll have to debride it. They'll have to do an irrigation and debride it and totally take out all that good tissue. Okay. So that's something to think about as you're thinking about the different cares that go on. Superficial burn, sunburn, right? Wash it, keep it cool. Biggest thing, don't put ice on burns. Okay. All right. Other things we have to pay attention to is burns are how is unfortunately how a lot of child abuse happens. So we have to be really careful with making sure we're asking for the story. And if the story doesn't match, or if the story keeps changing, again, if something's not right, it should trigger you like, this is questionable. So I know my son, he got partial thickness burns to the bottom of his feet because my husband at the time, it was summertime, we were grilling and we used charcoal grill, and he lit it and realized he didn't have enough briquettes in it. And so he grabbed the grill on the edge where it wasn't hot yet and put it down. And my son, who was probably about 18 months or 2 years, was barefoot in the backyard and walked across the grill grate. So not only did he have partial thickness burns, which means they were blistering white and fluid-filled sacks, they were grill marks on the bottom of his feet. So what do you think that looks like? I had to tell the same story over and over and over and over again because they were checking to see if my story matched, you know, and it was, I called telephone line to care. I asked them, they told me to put frozen peas on his feet. Okay. And so I did that and it made the burn worse. And so we ended up going into the hospital because like he had burned like the under part of his toes. And so I was worried that they were going to, they wouldn't heal right and contract down. So Burn Unit has amazing creams that they put on people, different Silvadene creams, different concoctions, great creams that they have. So that's something to think about as you're going in to get help and care for these, is the different creams they'll put on. It was blisters, so we left the blisters until they popped and stuff, and then so I have pictures of him with his feet all like bandaged up. So he was my one every year. Harley went to the ER for something. So we relatively knew him well. But we didn't go to a full thickness, and it was very direct in its spot. So you'll see like irons, like if a kid has an iron burn, right? And it has to, what are the two things that impact your burn?
How long it's been, how long the heat was on it.
Length of time and temperature it's at. So if you get somebody that has an iron burn that's like square on them, that was held on them for a while. That's not just a burn that like it fell on them and fell on the floor. So then you also have the bruising around it from the impact of the iron. That's, it was held on them, okay? Anything that's circumferential burns tell us that you were held in the water, okay? What does a circumferential burn mean? What's the circumference?
We're talking about circumference, right? I was going to say, is it?
Keep it simple, guys. I'm not about fancy. You know me by now, right? So circumferential burn. So somebody that, and pretend this is my foot because I can't get my foot up this high, but you put their foot in the water and they hold it in there. Circumferential burn is a burn that goes all the way around, okay? When we have a burn that goes all the way around, what are we worried about? If I have a burn that's going all the way around my arm, what am I worried about?
Necrosis?
Where?
To your fingers?
Yeah. I'm worried about blood flow to the tissue beyond it. Okay? So if you have somebody, you take care of somebody who fell in the fire and they get a circumferential burn on their forearm, I'm worried about their fingers in the fire, the fingers. Okay? Because remember, burn tissue, I don't know if you guys cooked a lot, but when you cook chicken with skin, that skin gets tight and it gets hard. And so you can have to do what's called an escharotomy, where you have to go in and cut that tissue open so they can get blood flow to their hand. Okay. So we see some of those burns. A lot of people, like in factories and stuff, if they get their hand or they stick, you know, liquid pours on them or something and it'll go around their arm. Or if somebody falls, a lot of times we'll get people that fall into stuff and their boots keep their feet safe, but like their pants don't keep their legs safe. And so you'll get circumferential burns like on their legs. So then we have to really pay attention to that. Do we have a pulse? Always want to pulse distal to the tissue, the burn area. Okay. We had a guy that one time that had a burn, his belt had held in whatever chemical or whatever that had hot, like some sort of like melted metal stuff, and his belt had held it in. So we got a circumferential burn all the way around his waist. So we had to cut that. And you can look up escharotomies and see some really gross pictures. If you dig that kind of stuff, go for it. I am not a burn nurse. Rachel is a great burn nurse. She likes all that groovy, gross stuff. I like broken bones way better. So
the guy that we had at the burn unit, he was in his truck making tea and it lit on fire. So he had like sandals on.
Yeah.
And so like you can see like all the lines from the sandals and where his jeans were.
Yep.
And so like we had to use, I don't remember what the actual name of it was, but they call it like the scream cream on him. I think it's like Sulfa something.
Yeah.
Probably
it.
Catalina probably knows what it's called. But when we put that on him, it was literally screaming.
Because with burns, what we have to do is we have to get down to tissue that hurts. We have to get down to, if it bleeds, it'll heal. If it doesn't bleed, it won't heal. So we have to get down to tissue that heals. And this is for any wounds. So that's why when you get wound beds, we want nice red, bleedy, weepy wounds. You don't want that white, yucky tissue because that's not bleeding. We have to go in and cut that out so that they do it. And so like the Scream Cream does that. It gets it down to that bleeding tissue that hurts really, really bad, but is really effective and really works well. Emily had asked me a question, I think, on the Muddy Questions one about with total body surface area. So say you just get the front of the face, that's 4.5%. Because the body surface area is a guesstimate, like we have a relative idea, but it's not a perfect. Use whole numbers. Okay, so if you get 4.5%, if you get a 0.5%, bump it up that extra percent. Okay.
So go 5? What do you mean?
Yeah. So yeah, you go up to 5. So like say you had all these different percentages added up, you would, and you ended up with like 40. I think the example one I have down for you guys below is like 40.5%. So you would do 41%.
Yeah.
Okay. So you'd round up because it is an estimate. But remember that urine output is what's going to be our big key. Like this is just a guide, but you may get a person that they don't need a ton of fluid because they are not shifting. If they're having a 60% burn, they're going to have a fluid shift. Like they're just are. And this is going to be someone you get shipped, but never fear. You can always call the burn center and they'll help you calculate too. Like, so say you're out, you're a travel nurse and you're working out in, Box Butte County or something, somewhere way far away. And you're like, I need to call, I don't know, call St. E's. They're the burn center that's in Nebraska, and they'll help you calculate your fluids and stuff like that. So they're really good about helping you over the phone, guide you, because they know this is a very specialized thing. My biggest thing that I want you to get out of this is knowing that we want to give them fluid volume, but this isn't like sepsis where we just throw 4 liters at them, trying to bring up their blood pressure. We have to titrate this and still be within control, because the burn center, they've talked about how many times they will get patients from somewhere else where they knew they had to give them fluid, but they didn't calculate amounts. So now they've had like 5 liters of fluid in and it's been an hour, and so then they have to give Lasix and give all this stuff to try and pull the volume off. So you're causing more complication if you don't do it controlled, right? And in sepsis, like when people are in shock, we're a little willy-nilly. We kind of say, okay, another liter. Like your blood pressure is still 80/40, another liter of fluid. Like we just do we titrate more. When people are in shock, I titrate more by blood pressure. With burns, we titrate more by that urine output and blood pressure. Okay, because your purpose of giving volume is to keep that blood pressure perfusing those 3 key areas. Okay, so you got to think about the why. Why am I doing what am I doing? What's the patho? What's my intent? Okay, if you know your patho, you know your intent, your interventions and your nursing priorities sort of just kind of roll right off of it. All right. Any other questions?
I had one last question.
Okay.
Maybe it's just not making sense in my head. It had something to do with the ABG stuff. Okay, so you know how like for let's say like metabolic alkalosis, we're talking about like someone that's like bulimic and vomiting, but wouldn't you think because they're vomiting, they're gonna have more acids, like in the case with diarrhea?
Diarrhea. What, what do you lose with diarrhea?
Are you losing?
If you have diarrhea, what are you losing?
Electrolytes.
You're losing electrolytes, but you're losing bicarb. Because think about, is in your gut, in your bowel, is it acidic or basic?
Should be acidic.
Nope,
No,
your stomach's acidic.
Okay.
That's why it's stomach acid. You never hear about bowel acid.
Yeah.
You hear about stomach acid. So yeah, so that's why your bulimic, your person that's throwing up, they're losing all that acid. But your person that is having constant, and we're not talking like diarrhea for a week, we're talking like diarrhea for a month. Okay. This is somebody who has a GI, they ate bad food and they get diarrhea, their pH isn't gonna get messed up, okay? Unless they're really, really bad. So this is gonna be somebody that is habitually throwing up and doing it.
Okay, I guess that makes sense. So it's where's the acid and where's not? Because I'm thinking like vomiting and diarrhea, the same concept, but you're still getting, those things out. But
right, yeah, it's which are you losing the acid or are you losing the base? And so that's why it kind of tweaks on it. But yeah, and my big thing, guys, like you can know the tic-tac-toe method. I think Jen had talked to me and she's like, the tic-tac-toe method works. You can use the tic-tac-toe method. I don't teach it. One, because I don't prefer it, because that doesn't help you understand what's going on. As LPNs, as even RNs, like people don't understand acid-base balance. What I want you to understand about it is acid-base balance is what kills people. Michael Jackson died of respiratory acidosis. He died because he stopped breathing because he was given a medication that sedated him. He was given propofol, which is an anesthetic, okay? So acid-base balance is actually kind of what kills us. And because of our acid base gets messed up when we're dying, right? So I want you to understand what your patient's gonna look like. What are they at risk for? Like when you see a patient who's in DKA, I'm worried that they're gonna go acidotic, right? I don't care if you know necessarily then I'll have the numbers. You will have a test question that has pretty much like what I did with the quiz, where it was, here's your set, what acid-base balance are you worried about? And then talks about a patient and which patient would fall with these numbers, okay? Think about what the patient's gonna look like. What kind of disease process are you worried about? What's the patho behind it? Not just, oh yeah, I memorized this, great. Okay, but even like RNs on the floor, when we're on 5th floor, they don't know how to read ABGs either. Like, I'm just happy, I'm like.
But then you get a situation, you're like, well, that doesn't make sense. You know what I mean? It's just
right.
Like,
and there are patients you're like, how the heck? Because the other thing that we have to understand is I didn't teach compensation, because that is like the body will not stay at an acidotic level. Your body will compensate. So if you're acidotic, your body is going to try and do like, so what kind of breathing does that diabetic ketoacidosis give people? You remember that? What kind of breathing does a diabetic keto, how do they call it?
Would it be like Kussmaul?
Your Kussmaul respiratory. So they're these fast, shallow breathing, because what your body is automatically trying to do is to kick out acid. It's trying to hyperventilate so that it can kick out the acid. And so your body will try and keep it going. When you're very basic, your body will have the, like, you won't be breathing as deep because it wants to keep the acid in.
Yeah.
So like yawning, the reason yawning's contagious is because our bodies are trying to keep balance like everybody else. When you yawn, you take a really huge deep breath and you blow out CO2. So your body's trying to, and even talking about yawning makes people yawn because our brains automatically want to be in that homeostasis piece, just like everybody else's. And so it's that like constantly trying to balance. Okay. So, and your respiratory therapists are your best friends when it comes to ABGs because they get 18 months to study one system. And they know it, and they know it very, very well. And they use the ventilators to tweak ABGs. So they're really good at it.
I was just talking to a respiratory therapist yesterday about, like, I was like, what do you guys do to treat coronavirus patients? And like, what's your protocol? And he was just like telling me all the stuff.
Mm-hmm.
To talk to him about ABGs.
Yep. They are like, I used to go to my respiratory therapist all the time in the ICU and be like, Dave, what do I do for this one? Or how are you tweaking the ventilator? And he'd talk to me about it and tell me, and I'm like, oh my gosh, they just are just such a vast wealth of information when it comes to that. Use your team.
You know,
healthcare is a team sport.
You know,
what,
how
Catalina?
RNs don't know how to use, like, they don't know how to read it on the floor. That kind of just makes me nervous. Like, what do? Use Google at that point?
They call their team. Because the respiratory therapist is the one that drew the ABG. Mm-hmm. We don't draw ABGs. Respiratory therapy does. And so they're the ones that interpret it. And like, we were just at the hospital, one of our last days there, and it was a rapid response, and they did an ABG. And like that patient was transferred to the unit. Like, again, ABGs are not, they're something I just want you to be sort of aware of, that they exist, and that it's a pH balance, and our body's trying to balance our pH. When you think of ABGs, don't think of, when you balance your budget, that very bottom number is like your pH. That's the number you worry about. The other stuff up here, I went out to Cane's, or I bought shoes, or whatever, like that just all adds up to that pH number, right? So that CO2 and that bicarb and all those add up to make that pH number, but it's the pH number that I really care about. The other numbers are the why. Why is the pH this? Like, why am I broke? Oh, because I spent way too much money, right? That pH is that like the, I don't know, black line number that you want.
Maybe
Okay.
if I budget, I'd understand that more. But.
Right? Like, oh, I spent too much money, so I'm poor now. Like, okay, you know, that's your pH. Oh, I have too much CO2. Okay, I'm acidotic now. So, okay.
He was telling me this is off subject, but I didn't even think about this, but he says that they've been using albuterol inhalers because they're more ideal. He said because the aerosols they try not to use because it puts the COVID in the air.
Yep.
And I'm like, I never even thought of that part of it, just like that small little thing.
Right.
But he said unless it's a negative pressure room, but if it isn't, then they don't give them the aerosol treatments because it's just like spreads it in the air.
Yep, and puts whoever's in that room at risk for it. Yeah. Albuterol inhalers, 4 puffs of albuterol inhaler is equal to 1 nebulizer treatment.
See, I didn't know that.
Yeah, I do that with my daughter. She does 4 puffs of albuterol, so we don't do nebulizer treatments, but it's equal. So it's just different delivery method. So, all right, guys. Well, thanks for some great questions. Hopefully this helped you put stuff together. I did put questions on the Muddy board. I'd make sure that you're looking at them and reading them and answering them. Monday, we'll do an open lab Monday, and then we'll do your test Thursday. So that way on Monday, we're going to put some pieces, we're going to kind of start putting all this together and start really thinking through how do we think through emergencies. So make sure you go through in the lab module, there's a video to help you start thinking about how do I think through an emergency and starting to tweak our focus from, you know, you guys are really good at getting all the information. And now we got to really start thinking about what information is really important. Okay. So.
And is that for the test, you said you had 2 options?
Yeah, on Monday, I'll put out a sign up board for an AM and a PM. I think the AM will be at 9 and the PM will be at 5:30 because I know people have like kids at home. And so hopefully people can like get someone to watch them by 5:30. And if you guys can't, like if something's going on, let us know. We can be flexible with times. Like we don't want time. I feel really bad when I see people have like their dogs barking at them or a kid sitting on their lap or whatever. So make sure that you're letting us know so we can help you because that's what we're here for. And we know, like if you can't start a test till 8 or 9 o'clock at night till kids go to bed, okay, like maybe we can tweak and alter it somehow, or maybe we can get up at 6 in the morning and do it in the morning before kids wake up. So, all right, let us know. Within range, I can't do 22 different times. I'll just be honest. So, but I can do a couple.
Last exam, like muting it to tell my daughter, like, go back in the room or turn the TV down.
Yeah. So, I mean, that's just one of those things where we get it. We know that this is not normal timing. So, all right. Have a great afternoon and get out and enjoy some sun before we get the rainstorms coming tonight, I think. All right.
Thank you.
Bye.
Thanks, Erin.
Uh-huh.
Bye. Thank you.
You're welcome. Hey, leave meeting.